So again, starting over, this station is pretty much called the Comprehensive Airway Management Program. So what this entails is, unlike the other salad stations, which really concentrates on managing the secretions while you're placing the advanced airway device, this is more centered on your initial approach to patient management. We come up on scene, our patients are found supine on the ground, mouthful of puke. We need to start from scratch. So what we're going to do is teach a program where we can manage those patients, work as a team, rapidly get that airway patent and secured, suctioned out, get them positioned properly, oral airway, nasal airway placed, high flow nasal cannula, bagging with a mask, getting them oxygenated as close as possible, because oxygenation is the most important thing here. They don't need the plastic in the airway, but they need the oxygenation in order to survive. So as we approach these patients, we're going to break into teams, and every member of the team has a specific job. Since you're going to be at the head of the bed, you're going to take in your suction unit, and we're going to have the suction bag modified. So inside of it, we have one adult size laryngoscope blade, one peds blade, a pediatric rigid suction catheter, and McGill's forceps. Everything we need to control that airway is right here in your system that you have with you. So as you approach the patient, you're going to take your rigid tip suction catheter, the Ducanto catheter, you're going to pull out your laryngoscope, and you're going to rapidly go straight down with your suction catheter, overhand grip, straight down as far as you can see, and you're going to clear that airway. Once you get as far as you can see, you'll take your laryngoscope, insert it in the mouth, and visualize that the hypopharynx is clear of all the fluids and secretions or blood, and that airway is clear for ventilation. While she's doing this, you're prepping your oral airway, nasal cannula, ready to hand it to her. So once it's clear, pull everything out, set it right next to your side there, because you'll need it later. And we'll get that nasal cannula, oral airway. And let's go with the nasal cannula here. And we'll have that nasal cannula at 15 liters per minute, providing that constant flow of oxygen through the entire code. And we're going to start BVMing. Grab your BVM, nice controlled ventilations. So nice, soft, steady squeeze, just enough to get that chest to rise, and slow, one breath every 7 to 10 seconds. Nice, slow breaths. Our other person, third person, is gathering positioning materials, whether it's a preformed wedge like we have here today, otherwise you're using couch cushions, blankets, pillows, anything you can find around the house to get this patient positioned in a 30-degree angle. So once he's ready, he's just going to tell you that we're ready to position. Also takes the weight of the heart off of the lungs, maximizing the residual capacity of the lungs, the alveoli that you can actually recapture with ventilation to improve oxygenation of the blood. And it really takes a lot of pressure off of the vena cava, so you can increase that preload to the heart as well. So all around, positioning is really important for these patients to maintain survivability. So now we're golden. We're oxygenating the patient. We have good control of the airway. We can take our time. Make sure our advanced airway is properly set up. Our laryngoscope is checked. Lights is nice and bright. ET tubes, the balloon is checked on the balloon on the ET tube to make sure there's no leaks. Preloaded with a bougie, stylet, whatever you're going to be using. And everything's lubricated, ready to go in order we're going to do it. All the time we take setting up is going to aid us in getting that first pass success rate with our ET tubes. What do you want to use to intubate with?
The video laryngoscope.
The Storts there? C.A.M.P?
Yeah, and then the ET.
Okay, so you got that ready to go. So once you're ready to go, we're going to pass over the BVM to your partner. He'll take over bagging. You're going to make sure all your intubation stuff is ready to go. So as soon as you're ready, again, you're going to have your suction catheter in your right hand, laryngoscope in your left. You're going to go ahead and tell him to clear the airway. And when he clears the airway, you're going to take the mask and that oral airway out with you when you go. So now lead with that suction all the way down. Get control of that tongue, displace that jaw forward, ease insertion of your blade. And once that blade's in the mouth, you can transition up to your screen if you want. Guide that suction down, make sure that hypopharynx is clear of fluids, and then you're going to pin it on the left-hand side of the blade right down in the esophagus, at least about an inch. About an inch in the esophagus, and that allows all that soft tissue to collapse around your suction catheter, seal it off so it's not taking all that apneic oxygenation away out of your oral pharynx. Now you can work on that good intubation view. and smoothly pass that bougie through the vocal cords. If the patient pukes through here, it's all taken care of. It won't wreck your view. So once it's placed, you can bring this over, grab it with your thumb, and then you can release it from your ET tube. And then just gently glide it over your bougie and place it through the vocal cords. Now at this point, secure it, inflate your cuff, make sure no more aspiration goes down there. And the first thing we want to do, since we know this airway was soiled and contaminated, is do a deep bronchial suctioning down through the endotracheal tube. Because again, the lethal dose in 50% of the patients is just 1 cc per kilogram of an acid aspirate. We have no control over how much they aspirate before we get on scene, but we have to assume that if they had a mouthful of vomit when we got there, they probably already aspirated some. So every milliliter that we can prevent in aspirating the patient might keep them below that 1 cc per kilogram lethal dose. And then we can transition immediately over to ventilation and start oxygenating the patient. So with this, you can stabilize your ET tube, remove your laryngoscope from the mouth, and we can get ready to confirm tube placement, end tidal capnography, listening, auscultating over both lung fields, make sure you have good lung sounds, no epigastric sounds. And once we're confirmed the tube placement, go ahead and secure your ET tube for the patient. It's highly recommended anytime you place an advanced airway in a patient, go ahead and pass an OG tube though. By passing the oral gastric tube, we can remove free fluids and air from the stomach, minimizing the risk of aspiration, minimizing that risk of fluid coming up during management of your airways. But anytime you have an advanced airway placed, try and remember to pass an OG tube on these patients. Perfect. Any questions on anything? Okay, the important thing is just practicing with this. We require practice every month from the crews on station. I'll go around from station to station out of the blue, bring everybody together and work through this so that the fire crews come over, our EMS crews are there, police officers come over, but everybody's trained this technique so when they get on these scenes of these patients, everybody knows what job they have to do. And from beginning patient contact, when you come across this patient supine on the ground, mouthful of puke, all the way through the positioning oxygen, it takes about 30 seconds is all it takes when everybody's playing on the same sheet of music and everything's practiced. But we do that monthly. Every month we keep practicing to keep it fresh in everybody's minds. And with this, our survivability rate, especially in cardiac arrest patients, have gone from about 8% and we're up to about 37% right now. So managing the airways properly does make a big difference.